emergency department from a nursing home. The nursing staff noticed a change in the client's mental status this morning at 7. So 3 hours of present disease, but probably it started earlier. The client appeared confused and disoriented. The staff assessed vital signs and sent the client to the ED via emergency system. Laboratory studies were done and the results have returned. The physical exam shows fever, tachycardia, respirations are normal. The blood pressure is 100/10, or 110/78. I was thinking that to interpret this blood pressure, if we see the blood pressure like it's present here, it's perfectly normal. It's classified as normal. But I want to warn you about something. To decide if the pressure is not low, isn't low, you need to know what is the base, the usual blood pressure of the client. Because sometimes there are clients that normally they have high blood pressure, okay? And, especially in old people, in which doctors are more compliant in what is considered normal. So maybe they allow the client to have, for example, 160/90, which is not normal. This is hypertension stage 1. But in old people, especially with atherosclerotic arterial disease in the brain or in the coronary arteries, doctors don't want to have very low blood pressure because the client becomes symptomatic. So if this client usually was 160, supposes, and in a supposition, and now has 110, has a drop of the systolic of 50 millimeters of mercury, and this is too much. So the interpretation of this blood pressure in a clinical, real life clinical scenario need to be taken with a grain of salt, because you need to know the basal, the usual client's blood pressure. So in this moment, we need to acquire, with this scenario, some experience, some clinical judgment that to evaluate a normal blood pressure, especially in an old person, is good to know what is the basal blood pressure of the client. We don't know it. It's not given in this scenario. A good scenario probably would give you, so in a scenario in Nclex would give you this information. But now you know how to elaborate mentally if this situation presents to you. The oxygen saturation in room air is normal. So this is the presentation. So let's go to, it is a bank, it is ATI. Is this ATI? Yes, it is ATI. Okay, copy and paste scenario. And the first question that they asking us is, click to highlight the client findings that requires immediate follow-up. It's important that if you are in your test, in your English, you pay attention what means immediate. Immediate means that it's right now. It is manage this like an urgency or emergency. So I don't know if, for example, the client has past medical history of diabetes mellitus type 2 diagnosed 15 years ago, and the client is not coming, the present disease is not in a severe elevation of the blood sugar producing a specific discompensation of diabetes. This is not something to immediate follow up. And this is what this kind of question is exploring. If you can discriminate, if you can tell apart what is immediate and what is important but not immediate. Like, for example, past medical history of diabetes or penicillin allergies, etc. So let's see what is immediate in this client. Okay, the fact that it's 68 years old is not immediate because it has not been changed. And the fact that it's coming from a nursing home is nothing that is immediate important because it's not important. But noticing a change in the client mental status, acute, as described here, is important because you know that in old people, different alteration of homeostasis, like the oxygenation, like the electrolyte levels, especially in sodium, like blood pressure, like especially hypotension, no? Like infections, yeah, can present only with alteration of the mental status. A part of the diseases that are specific of the brain, the encephalopathies, the infections in the brain, and the como se llama, the strokes, the vascular disease. So it is important. The client appear confused and disoriented. It's reinforcing that for that reason, we need to agree that this is also important. The client was assessed and sent to the ER via EMS. This is not immediate follow-up. Laboratory studies were done and the results, this is not what I need to highlight. So vital sign, the temperature is important because now what suggests that this alteration of the mental status is not hypoxia, is not hypoglycemia, is not hyponatremia, is not a stroke, is an infection, and we need to find where is the infection. This is what is called clinical judgment. When you start in front of a client, a real life client, you see a series of information, then you start ruling out possible diagnosis, and you are, reducing the possibilities and focusing on the most probable diagnosis. And once we have a diagnosis, we know what to do. Tachycardia is important. Is translate distress activation of sympathetic nervous system, but the respiration is normal. This normal respiration suggests that the infection is not in the lungs, is not in the respiratory system. No, could be in other parts. And the blood pressure, I cannot highlight the blood pressure because this blood pressure is normal. But I mentioned this detail in a good clinical scenario, like the one that appears in Nclex, could be very important that they give us the base or usual blood pressure. And if there is a drop of the systolic blood pressure, more than 20 millimeters of mercury, the usual basal, okay, blood pressure, this should be considered like an hypotension. The oxygen saturation around air is normal, which also supports our opinion that the lungs are not the cause of this fever and this infection condition. So let's see what says the laboratory results. Red blood cells, 4.8 million is okay. The white blood cells are increased. This guy has 16,000 white blood cells. The hemoglobin is normal, and the hematocrit 3 times 15, 45, so is concurrent with the hemoglobin. Doesn't suggest dehydration. The platelets are normal. There is not a consume of platelets. Let's see the urinalysis. That should be the first test to investigate infection. The specific gravity is normal, doesn't suggest dehydration. The pH is acid. This is a normal pH for the urine. The urine can be very acid. Protein negative, glucose negative, ketones negative, urobilinogen, which is a derivative of the bilirubin, okay, negative and negative. But then we have traces of blood. Trace means a little amount. Leukocyte esterase is an important test that is reported in the urinalysis and even can be determined with a dipstick test that can be done by the own nurse. Positive. This is an enzyme. You know that anything that ends in ASE, ACE, is an enzyme. This enzyme is produced by the white blood cells that you know are also called leukocytes. This enzyme should be negative in the urine because in the urine shouldn't be an important amount of white blood cells producing this enzyme. If this enzyme is positive, it's because you have a lot of white blood cells or leukocytes fighting infection in the urine. So it is very suggestive of infection. This is another test that you need to know. Nurses need to know it, and you need to know that for your Nclex. Nitrite. This is a substance produced by the bacteria, specifically the gram-negative bacteria that with frequency infects the urine, abnormally infects the urine. Okay, and those bacteria produce this substance. The nitrite should be negative in the normal urine. When there is an infection, those nitrites become positive. Notice that in this scenario of a question bank and in the book and in the real life and in your Nclex, they use these two tests that can be found, these two values that can be found in the simple urine analysis as a proof of urinary tract infection. The urine should not have bacteria, and this client is having many bacteria in the urine. So those values, okay, suggest urinary tract infection. The presence of a small amount of blood could be found in any urinary tract infection because the inflammation of the mucosa. So now with this, we have already a diagnosed, okay, of urinary tract infection. But now in this question bank, they give us another question. The nurse reviews the assessment finding and lab result. For each client finding, click to select the finding that is most consistent with the condition of urinary tract infection or septic shock. So they want us to discriminate if the client is only having a urinary tract infection localized in the urinary tract, or if this infection has generalized, producing what is called a septic shock, okay, and which is a more severe condition because it's translated a generalization, a dissemination of the infection beyond the urinary tract with an inflammatory response that can produce shock. So this is what the question is asking us. Each finding may support more than one condition. Uh, the, the parameters that they are asking are confusion and disorientation, temperature, heart rate, and white blood cells count. Uh, I think, my opinion, if I cannot advance in this question from a bank without refreshing my concept of what is septic shock. And quickly before starting the class, I went to to oh Lord, okay, to to download, okay, a something that coming from the peer reviewed, okay, literature. So we 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 look in the National Library of Medicine, something about septic shock, and what is said here, sepsis syndromes span the clinical continuum with variable prognosis. Septic shock has the most severe complication of sepsis, uh, carry out high mortality. Septic shock occurs in response to an inciting agent, which causes both pro-inflammatory and anti-inflammatory immune system activation. Okay, let's see more specifically, uh, what is said here about the pathophysiology, shock. Okay. Sepsis is clinical state that falls along a continuum of pathophysiological states, starting with systemic inflammatory response syndrome. So look at this term, because in your Nclex you can have this term mentioned, no? Systemic inflammatory response syndrome, SIRS. This is something used frequently and sometimes interchange, okay, with the word septic shock, and ending in multi-organ dysfunction syndrome, MODS. So this is the sequence. This is sequence, okay. This is the sequence. The sequence is an infection that evolved to systemic inflammatory response syndrome, then to septic shock, and then to multi-organ dysfunction syndrome. Um, uh, just a moment. Um, okay. Um, so it says the earliest signs of inflammation are heralded by the following: fever, temperature higher than 38, or hypothermia. So this is an interesting detail, no? That either fever or hypothermia, can be manifestation of an infection, like in this client, no? Um, 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 the other is, well, tachycardia. It is tachycardia, which is a non-specific condition. Tachypnea. Okay, so it's interesting that our client has no tachypnea. Did you notice that? Uh, um, it's rare to have a client with an infection, fever, and without tachypnea, more than 20 breaths per minute. And leukocytosis, they say white blood cells greater than 12,000. So it's interesting because, I didn't remember exactly that this is the threshold, the limit that the people that know about this establish. But sometimes leukopenia, sometimes there is consumed of white blood cells and there is leukopenia. So white blood cells less than 4,000. Um, with or without bandemia. Bands are immature white blood cells. So independently of the presence or no bandemia, those alterations of the white blood cells are suggest that. So let's go back to our client. Let's go back to our client. Our client has leukocytosis more than 12,000 and has fever, 38.9, has tachycardia. Nevertheless, is not having, okay, hyperventilation, and it is contrasting with those criteria of the parameters that they use initially in those clients. They say the presence of two of these four clinical signs is necessary for the diagnosis of systemic inflammatory response syndrome. Guys, this is the first step in the evolution, the clinical evolution of a sepsis, of a septic shock. First, the client has the infection, and the infection is systemic, so spread beyond the site of the infection, yeah? And then having at least fever or hypothermia, uh, leukocytosis or leukopenia. And it's important to more or less memorize what is the threshold that they give us, okay? And the other possibility, tachycardia, that is very unspecific, and tachypnea, that call the attention that is not present in our client. But our client has at least two, has fever and has leukocytosis, has three, has tachycardia. Okay, so we can diagnose until this moment systemic inflammatory response syndrome. After that, notice that I'm presenting to you the literature that confirms that it is a sequence. You start with an infection that is localized. Then this infection is severe enough as to evolve as disseminate and becomes producing a systemic inflammatory response syndrome that can be suspected by those parameters: fever or hypothermia, leukocytosis or leukopenia, tachycardia, tachypnea, yes? And then after that, the systemic inflammatory response syndrome with an infectious source in our client, an urinary tract infection, suffices the clinical definition of sepsis. So our client has the clinical diagnosis of sepsis. Why? Because has a urinary tract infection, and has three of the parameters to diagnose systemic inflammatory response syndrome. Do you agree? So now our correct diagnosis based in evidence, and remember the level of Nclex is evidence, is that our client has sepsis. Why? Because it has a signs and symptoms of a systemic inflammatory response syndrome, which means that systemically all the body is responding to an inflammation that is not anymore localized in the urine. Now it's disseminated, and we have an infection, and it's the diagnosis of sepsis. No septic shock, sepsis. So reinforcing the concept for you that need to know that for test purposes, sepsis is when we have an infection and the infection has spread beyond the initial infected site. That could be the appendix, could be the kidney, could be a soft tissue, etc. And now is producing inflammation all over the body, a systemic inflammatory response syndrome manifested by fever or hypothermia, leukocytosis or leukopenia, tachycardia, and tachypnea. Those are the criteria, the parameters, the evidence base that are used for the adequate nomenclature or definition of those conditions. Now it continues with, it is another step beyond the present step that we have, with the development of hypotension. I'm repeating, with the development of hypotension, yeah, now they are adding low blood pressure. Guys, why we need to have blood pressure? Because the heart need to move the blood from the lungs, okay, where the oxygen is. The lungs have the oxygen, but the heart need to move this oxygen through the hemoglobin and the circulation, need to be moved to what? To the cells that you have in all the organ tissues that you have in all your body. So you need to move the oxygen from the lungs to the brain, the fingers, the liver, all the your body. Yeah, and to move this blood, you need pressure. Okay, the same way that you need pressure of water to have water coming out the faucet of your kitchen, you need pressure of blood to move the blood, okay, from the lungs and the heart to all the tissues of the body. And if this pressure drops, then the blood is not moving sufficient. And then the consequence is that those cells in the tissues are not going to receive enough amount of oxygen. Don't forget that this oxygen is needed second by second for the aerobic metabolism. That is no more than the transformation of the molecule of glucose in the mitochondria, the transformation of the molecule of glucose in the mitochondria into ATP, the energy that allows the cells and the tissues and the organs to work. So to produce energy, you need to burn in the mitochondria glucose, the molecule of glucose, but in presence of oxygen. If there is not oxygen present in the cells cannot burn the glucose to produce ATP. If there is not energy, it's the same as a computer or a telephone that runs out of battery. The cells turn off and start dying. So that's why they say that in this scenario that we have an infection and we have a systemic inflammatory response syndrome, if we develop hypotension, okay, tissue demands are not adequately met by tissue oxygenation. Not enough oxygen is reaching the cells, and the patient is now defined to be in severe sepsis. The decline in peripheral vascular perfusion oxygenation leads to cellular and metabolic derangement, most notably a shift from aerobic to anaerobic respiration. Remember, aerobic metabolism is the fact that we are in this moment burning glucose in all the cells of our body in presence of oxygen, and we are producing ATP. When there is not oxygen, our metabolism shifts to anaerobic metabolism. What happens in anaerobic metabolism when we don't have oxygen or enough oxygen in the cells? We don't produce enough energy, not enough ATP. And second, we produce a venom, a toxic substance, a poison that is mentioned here, with ensuing lactic acidosis. We produce a venom called lactic acid when we don't have oxygen in the cells to burn the glucose. When we do have oxygen in the cells, which is the normal, what we produce, the byproduct is carbon dioxide, and we can breathe out the carbon dioxide. But when we don't have oxygen, a part of not producing enough energy, we produce a poison called lactic acid that cannot be excreted from the body and builds up producing a lactic acidosis. So is this client in this stage? If the client were in this stage, we would be having, in the stage of severe sepsis, we will having low blood pressure. But what is our problem? I mentioned that at the beginning. The scenario, the question bank is not giving us enough information because this blood pressure that clients brings is normal, but we don't know if normal for the client because maybe the client has usually a much higher blood pressure, and in that case we should diagnose hypotension even if the values are still considered in the normal range. We don't have this information. We don't know if there is low blood pressure, but we suspect that yes, because a 68 years old usually have a little higher blood pressure. So probably that. But this is a defect. This is a fail, a flaw of the scenario as written by the person who wrote this scenario. Should be established with one the basal blood pressure of this old person to determine if this is hypotension or not. And second, if the client were having septic shock, this client should be having metabolic acidosis. And if the client were having metabolic acidosis, the client should be compensating with hyperventilation. The Kussmaul respiration, the deep and more frequent respiration that is seen as a compensation in metabolic acidosis. And this client is not having this respiration. Okay, I want you my smart, okay, students of MRU to know this clinical judgment of shock. First, it was given to you in MedSearch because I taught MedSearch in MRU. I know it's included ¿cómo se llama? In the lesson plans in the syllabus. Okay, so this is explained to you what is shock and what that is different type of shock. And now I want you to understand what is happening in shock. Shock is a syndrome. You can summarize shock is a syndrome in which the blood pressure is so low that the blood is not properly moving from the lungs to the tissues, transporting the expected amount of oxygen. So what occurs in shock is a tisular hypoxia, and the hypoxia shift the metabolism to anaerobic, and this is going to bring a lousy production of energy, which deteriorates the cells, the tissues, and the organs, and the production of lactic acid and lactic acidosis. You need to know that one of the protocols that you will learn after you pass the Nclex and start working in the hospitals, in the ER, that any client that with suspected infection, suspected inflammatory response syndrome that we already defined, not necessarily in septic shock, must be determining the levels of lactic acid in blood. The elevation of lactic acid values in blood in these clinical scenarios, the real life clinical scenario, somebody with any infection, define that the client is having a systemic inflammatory response syndrome with impairment of the oxygenation. And lactic acid, determination of lactic acid in the blood is a super important test to define if the client is having a septic shock or not. Sadly, this clinical scenario that I found copy and paste to discuss is not mentioning the level of lactic acid. But I'm pretty sure that in your real test in the Nclex, this value could be included because it's important to support the pathophysiology of the systemic inflammatory response with septic shock. Okay, so after this explanation, that is important to understand, not to memorize, to see the sequence, the evolution of an infection from a localized infection to a septic shock with all the implications, okay? So knowing that the localized infection evolved to a systemic inflammatory response syndrome that is not septic shock, but is when the infection is producing fever, leukocytosis, could be the opposite, could be hypothermia, especially in babies, in infants, and in old people, or hypothermia or leukopenia, in contrast with leukocytosis and fever. And the tachycardia and the increased respiratory, the syndrome of inflammatory response syndrome can evolve to septic shock. Septic shock is when the blood pressure is dropping and the blood is not moving efficiently enough as to provide oxygen to the tissues. And when this occurs, something new is going to be produced, lactic acid, and a metabolic acidosis appears. And when this septic shock is not corrected properly, okay, is not correctly, is going to appear the death of cells, and with the death of cells, the death of tissues, and with the death of tissues, the death of organs. And then appears what is called multi-organ dysfunction syndrome, which is like a domino or a snowball effect that usually is the irreversible stage of the septic shock. When this appears, there is no way of going back. And it's important for nurses to understand the importance of diagnosing this clinical situation at this level when the client and the pathophysiology and the problem is reversible, can be fixed. When we allow this to evolve to the multi-organ dysfunction syndrome, generally the shock becomes irreversible. And as you notice, it's not so difficult. Is something that we can understand. It's something that that we can you don't need to memorize that, but it's important to understand the pathophysiology of the shock. And I can bet that this is frequent question in Nclex, all those details in different type of questions. Understanding the pathophysiology, you would be able to answer the question. So we have here a client that have systemic inflammatory response syndrome because it has a urinary tract infection, but we don't have enough information as to define if the client is presenting shock, septic shock in this case, because we don't have a, a, a clear definition of hypotension, and we don't have values of lactic acid to define if the pathophysiology of the septic shock is happening. And we don't have evidence of metabolic acidosis, mainly based in the normal respiratory rate. So I think that our client is still not in septic shock, is in SIRS, in systemic inflammatory response syndrome. The urinary infection has generalized, but is still not in septic shock based in those criteria. Guys, if you don't follow me, if you have still something that you don't understand, please ask me. I'm going slowly because I, more than memorizing this, I need you to understand what I'm explaining. If you understand, you will not forget. If you won't forget, when you have questions like this in your Nclex, you'll be able to answer properly. Well, with the development hypertension, tissue demands are not covered in oxygenation. The patient is now defined as severe sepsis. The decline in peripheral vascular perfusion oxygenation leads to severe metabolic derangement, and you have anaerobic condition, ensuring the production of lactic acidosis. Tissue hypoperfusion may also be manifested by signs of end organ damage. So the end organs are the kidneys, the liver, then the lungs, then the brain, and probably the last is going to be, well, here is also the intestine. The last is going to be the heart. When it affects the heart, the patient dies. Which is the organs that usually are affected first? The kidneys. I always, when I teach that, I say that the kidneys commit suicide when they see that there is a shock. So generally the organs that you know that are the most susceptible um, to being damaged by the septic shock or any shock are the kidneys. Liver, liver is also quickly, affected. The GI system, the intestine, quickly, are affected with necrosis of the intestine, disruption of the mucosal barrier, complicating even more the sepsis because now the bacteria, the normal flora of the intestine can be translocated to the circulation. Then the lungs. Remember this syndrome that is also important for your Nclex, okay? That is called acute respiratory distress or dysfunction syndrome, ARDS. Yes, that is this condition that produces a non-cardiogenic pulmonary edema with severe impaired gas exchange, with very severe hypoxemia that requires assisted ventilation. The one that is convenient to put the client in prone position to favor the drainage of the liquids in the lung. The ART, this is a manifestation of frequent. The most common cause of ART is sepsis, is this condition, sepsis, septicemia. And then, of course, the brain is going to be affected. And last the heart, and when the heart, stop working, yes, you are dead. And this is what is called the multi-organ dysfunction syndrome, when the end, okay, organ damage, such as pre-renal azotemia. Azotemia is when you have elevation of the BUN and the creatinine, or transaminitis, when the liver starts, okay, malfunctioning, and there is an important significant elevation of the transaminase. Transaminase is at the AST and the ALT, okay, that are the liver function tests, that when there is damage of the cells of the liver, elevates a lot. The difference in oxygen supplies and demand can be monitored during resuscitation by trending the mix being, okay, this is too specific of ICU nursing. So the quantification of the level of CO2 that is expelled, okay, at the ends of the expirations, and the determination, the mix venous saturation, this is too much. This is too much. It is too much for entry level generalist nursing. But when you specialize, you like ICU nursing, and you start specializing, you are going to be trained in understanding what is this evaluation of the oxygenation and the mix, the blood that is coming from the organs, and why it's so important. Let me continue reading quickly here. So you have a better understanding this. When sepsis-induced hypotension remains refractory to initial management of fluid resuscitation, it is important because this is frequently tested. What is the first, initial, and most important intervention that you expect the physician will order to revert, to save, to improve the client's condition, and is the fluid resuscitation? So this client that is having infection, systemic inflammatory response syndrome, and hypotension, the and of course elevation of the BUN and the creatinine as a manifestation of pre-renal before the kidneys, no? Renal damage. The most important is the administration of fluid. So this is the first step in the management of systemic inflammatory response syndrome, and in the management of sepsis, and in the management of septic shock. Um, so the fluid resuscitation is the administration of isotonic fluids, normal saline or lactated ringer. The tendency nowadays that I've read, okay, about is not using lactated ringer because you have enough lactate, okay, in these clients. It's better to administer normal saline. And the other thing that can be administered are colloids like albumin. Okay, so but it is important. You can have that in a clinical scenario of sepsis, because many of my students have already told me that they had in their test sepsis as a clinical scenario with clinical case of sepsis. What you anticipate is going to be the initial management is fluid resuscitation. Fluid resuscitation. Okay. I don't think it's going to be a question, but you know that shock is a syndrome, and there are different type of shock. You know that you have hypovolemic shock, you have the cardiogenic shock, you have the obstructive shock, and you have the distributive shock. The hypovolemic shock is the easiest to understand and the best known by all of us. Is somebody that have a wound and have an hemorrhage, and the magnitude of the hemorrhage, the loss of blood, is so important that the blood pressure drops and the client enters in shock. And the intervention is to replace the lost volume. But at the end, what is happening in the tissues is the same. The cardiogenic shock is when you have a normal amount of blood, but then the one that is failing is the pump that moves this blood, the heart. And the most common cause of cardiogenic shock is the massive myocardial infarction. There are others, but the most important that we as an entry-level nursing is MI, the most important management problem with ¿cómo se llama? With cardiogenic shock. Of course, the management of this MI, specifically the as soon as possible reperfusion. What is reperfusion? In MI, there is an artery, a pipe that is obstructed, yes? Doctors can go there to this pipe and can mechanically remove the obstruction, reestablishing the blood flow as soon as possible. Can be done through catheterism to transluminal coronary angioplasty, can be done by bypass CABG, no coronary artery bypass graft, open heart surgery, or can be done when it is not possible with thrombolytic therapy. The reperfusion therapy, so reestablishing the blood flow through the obstructed coronary artery, is the intervention that is expected in the cardiogenic shock. Yeah. The obstructive shock. When you have, for example, a massive pulmonary embolism, that a clot that forms in the legs, move to the pulmonary artery, and this clot is big enough as to obstruct an important branch of the pulmonary artery, then the blood cannot move from the right heart through the lungs until the left heart. This is an obstruction in the blood flow inside the lungs. Blood stays in the veins, cannot move from the right heart to the left heart. No blood is reaching the left heart. There is an obstruction. The left heart, the left ventricle is dry or almost dry, and too little blood is moved to the aorta. And for that reason, there is a shock, a severe hypotension. Other causes of obstruction, cardiac tamponade, in which an exaggerated amount of liquid around the heart squeezes, strangles the heart, and the blood cannot enter, cannot live. As you notice, the intervention in those cases is to remove the obstruction. In the case of the massive pulmonary embolism, is the treatment with thrombolytic therapy. In the case of cardiac tamponade, a pericardiocentesis. Okay, so those are causes of obstructive shock. And the distributive shock, which is the one up to which belongs the septic shock, is very weird and requires understanding. The blood pressure in the arteries is given by the level of vasoconstriction that all the arteries of the body have. This is called vascular tone or vascular resistance. So the blood vessels, the arteries of the body cannot be too open, cannot be too narrow. It can be the right dilation, the right size. Yes? And that is managed mainly by the sympathetic nervous system. But sometimes certain substances can produce a massive, exaggerated vasodilation in all the arteries of the body at once. Sudden, acute, exaggerated vasodilation in all the arteries of the body. And not only vasodilation, also open holes in the walls of those arteries in all the body, allowing the water, the liquid of the blood that is inside these pipes to spill into the interstitial space, to spill into the flesh. So the consequence of this massive vasodilation is that the pressure of the blood inside the pipes drops. So the cause of the hypotension is the excessive vasodilation. What can produce this vasodilation? Okay, endotoxins that are inside the bacteria, especially gram-negative bacteria, that can be released in case of sepsis, where the bacteria are circulating in the blood, This endotoxin can produce this vasodilation. Histamine, this substance that participates in the allergies, when there is a massive release of histamine, histamine, allergy, antihistaminic, Benadryl, yes, histamine, when there is a massive amount of histamine release, can produce that. When we have that in ¿cómo se llama eso? Anaphylaxis. In anaphylaxis, yes, when you have somebody that is very allergic to penicillin and receive penicillin, or very allergic to bee, venom, and have a bee sting, etc., etc. The other cause of distributed shock is the neurogenic shock. Sometimes when there is a spinal cord injury, the loss of the sympathetic nervous system activity below the level of the transection of the spinal cord, okay, produces a massive vasodilation of the blood vessel, producing the hypotension. So sepsis, um, anaphylaxis, and the neurogenic shock that we see in spinal cord injury are three representatives of the distributive form of shock, in which the blood pressure drops, not because we have hypovolemia, the volemia is normal, not because the heart is failing, the heart is okay, it's not obstructed, it's because massive vasodilation of all the arteries of the body producing hypotension. Too much vasodilation, hypotension is something that you can understand. Yes, and yes, this is the septic shock is a form of distributive shock. Um, um, so septic shock is distinguished from other shock states as a distributed type of shock. The action of a combination of inflammatory mediators, histamine, serotonin, superradical lysozyme enzymes, etc., elaborated in the response to the bacterial endotoxins lead to a marked increase in capillary permeability and concomitant reduction in peripheral vascular resistance. The same that I just mentioned in more maybe simpler words. This translates not only in reduction of the afterload, but also the preload, declines in the venous return from third spacing, and the result reduction in stroke volume in accommodated initially by elevation of the heart rate, compensating a septic shock. Yes, that's why elevation of the heart rate is looking for compensation. Elevating the heart rate, we try to compensate the decreased cardiac output. As a result, the patient is initially in a hyperdynamic state that is characteristic of the septic shock. Okay, so I think that we have enough theory. Um, enough theory. I think that we have enough evidence. No, it's not evidence. Information about of what is just a moment, guys. I'm distracted. Okay, of what is our clinical scenario. So ask me questions if you have still doubt, but I hope that you will be with me in the critique of these questions. Because remember, sometimes the student surpasses the professor. Sometimes when the student study, then get enough information as to surpass the professor that is asking you the question. So now there is a question that is asked to us. The nurse review the assessment finding and lab result for each client finding. Click to select the finding that is most consistent with the condition of urinary tract infection. So a localized infection in the urinary tract or septic shock. So a systemic inflammatory response syndrome with infections that define sepsis that is going beyond that and is producing hypotension, decreased tissue perfusion, decreased tissue oxygenation, and deviation of the metabolism from aerobic to anaerobic with production of lactic acid, with initial compromise of the target organs, the end organs, kidneys initially probably. So is this just an urinary tract infection, or is this a septic shock? So they are asking us to discriminate between both. But the parameters that they are giving are confusion and disorientation. This does this finding, this clinical finding, doesn't allow us uh, uh, discriminate, differentiate urinary tract infection, because in an old person we can have confusion and disorientation as a manifestation of urinary tract infection. And in any client that have shock, we have confusion and disorientation because the brain is not receiving enough blood flow and enough oxygenation. So this parameter doesn't allow us to discriminate a urinary tract infection, a localized infection, versus a systemic inflammatory response syndrome in presence of an infection, producing hypotension, producing hypoxia, and anaerobic metabolism. Temperature elevated. We cannot discriminate the two conditions with the temperature, because both conditions can produce or elevation of the temperature. Urinary tract infection can produce fever. Septic shock can produce fever. But don't forget that especially in babies and in old people, both could produce the opposite, especially the septic shock, which is hypothermia. Hypothermia, a temperature less than 97.5. Heart rate 110 regular. Well, this is tachycardia. Tachycardia is a compensation, can be seen in both, because in urinary tract infection, we have fever, we can have tachycardia. Yeah. What we know is that the tachycardia in septic shock is to compensate the hypotension, because this is on the decreased cardiac output that you see in shock. So it is not helping us to discriminate a localized urinary tract infection from septic shock, because both could be producing tachycardia. In the case of the urinary tract infection, the tachycardia is because the fever. And in the case of the septic shock, the tachycardia is also because as a compensation of the decreased cardiac output. White blood cells increase can be seen in urinary tract infections and in septic shock. Nevertheless, the severity of the leukocytosis suggests a severe form of systemic inflammatory response syndrome, or sepsis, no? But it's not defined. Is in either one you can see, okay, elevation of the white blood cells above 12,000. So what is missing here? Uh, Hypotension, if there is or not hypotension. If there is hypotension, you don't see that in urinary tract infection. You see that in septic shock. What else is important here? Lactic acidosis, the presence of lactate in blood elevated. If the lactate is not elevated, is urinary tract infection. But if the lactate is elevated, suggests septic shock. You understand? And what else could be here? The compromise of an organ, for example, pre-renal failure. You don't see pre-renal failure in urinary tract infection. You see pre-renal failure in septic shock. So these questions need more element to include what we just studied, or the pathophysiology of the septic shock, to being able to discriminate if this client is having just a simple urinary tract infection or a septic shock. That was the intention of the question, but the question is failing in giving us the parameters that allow the discrimination, the differentiation between one and the other. Do you agree with me, or you don't understand my point? Oh, you are sleeping. Okay, no
Yes,
problem.
Professor. Thank you.
Okay, okay. So based on the assessment findings and diagnosis, the nurse creates a plan of care. Complete the following sentence by choosing from the list of options. This kind of question is very common in the clinical scenario. So in this question, say the client is at highest risk for developing, and then we need to choose between these three: septic shock, urinary incontinence. This condition is not associated to urinary incontinence. You can't rule out that. Renal injury. Well, could be you can have a pre-renal, renal failure, but it is going to be secondary to septic shock. So the best option to choose here is septic shock. So even with the objection that I have to the question, the best to move here is septic shock. As evidenced by, so now you have mental status changes. The mental status changes is non-specific. It's not enough to diagnose shock. Urinalysis only are diagnosing infection. To have septic shock, we need to have the values, the parameters that I mentioned before. So the best option that you can move here is the vital signs. Okay, the vital signs, even if the vital signs are not concluent. But I suspect that this client is having hypotension, but the scenario failed in giving us the basal blood pressure of this client that probably was much, much higher than the present blood pressure, and should give us in the lab result because it's a routine. It's done in the lab in hospitals when they admit a client with a systemic inflammatory response syndrome and an infection is the level of lactic acid. With these two parameters, I could perfectly, be sure that we are in presence of a septic shock. But we don't care. We know that in Nclex, the questions are very going to be very, very good quality, and we are now mastering the pathophysiology of this condition. Okay, let's see what else they say here. It is the same story. Here, the battle sign, we say that this is an evolution here, 10:30. So half an hour later, no? The nurse reviews vital signs and lab results. The client has been diagnosed of urosepsis. It is interesting that this term is used frequently in the jargon, the medical jargon, when because it's one of the most common origins of sepsis, the urinary tract infections originated, sepsis. So it is called urosepsis. Half an hour later, as it looks like the doctor saw the clients and antibiotics, of course. It is important to take a specimen of urine for culture and as soon as possible initiate antibiotics. Remember that we need to take the specimen for culture before initiating the antibiotic, but it takes uh, no more than 5 minutes. Because even if the client is not urinating, you can use a straight catheter ordered by the doctor to obtain a sterile specimen for culture. Acetaminophen, I suppose that is for the fever. And intravenous fluid, I convince you with evidence, and there is more evidence in this literature you can find, that the way of reverting this condition to prevent the evolution to the um, irreversible stages of shock is the administration of fluid. The nurse plans to take which of the following measures? Okay, several that apply. Let's see what we can ask here. Use a cooling fan. Okay, fan. Okay, use a cooling fan. Give a tepid sponge bath. Provide a cooling blanket. Start intravenous fluid. Administer the acetaminophen, start the intravenous antibiotics, place ice pack in the axilla and groins. So based in our knowledge, let's answer in this cellular apply the one that we are absolutely sure. Start the IV fluid, we are absolutely sure. Administer acetaminophen is we are absolutely sure is indicating this client, and start the antibiotics is absolutely sure. So let's go to the way of lowering the temperature to this client. Uh, the other intervention that we see here are interventions oriented to lower the temperature. Okay. Uh, it's important that when we lower the temperature to avoid the chills, to avoid the client having, the rigor of the chills, because it is going to be very uncomfortable and is going to produce more fever. Cooling blankets are used in the hospitals for a client with fever to control the fever. So cooling blanket is an accepted method of reducing the temperature. And probable, if the client is in ICU, they are going to use cooling blanket, a part of the acetaminophen, to reduce the fever. So you can be sure that cooling blanket, okay, are used in those cases. If we use cooling blanket, using a fan or using a tepid sponge bath or placing ice packs on the axilla and groins should not be indicated. My recommendation, if you are in Nclex and you have a select all that apply question, go to the items that you are absolutely sure. So no problem with these three. And then incorporating to you that in the hospital, when we want to reduce fever, we use cooling blanket. We can incorporate this knowledge. But definitively in this kind of ICU, the other indications are not necessarily the most important. Nevertheless, I brought some literature here in this scenario to to educate ourselves. So after I give you my recommendation for test purposes, it is for the test, because this preparation is to prepare for the test. UTI often cause fever, and measures need to be taken to reduce the fever to promote comfort. Non-pharmacological therapy for fever work by increasing the heat loss by evaporation, conduction, convection, and radiation. That are the four ways of getting rid of heat. Avoiding the stimulation of shivering, okay, is important in deciding which non-pharmacological measure to use. Shivering increases energy expenditure and therefore is not desirable for reducing body temperature, especially in an already stressed physical state. Entonces, it is an important concept. The shivering is that brings with the chills, okay, that is associated when we receive, this kind of intervention like ice packs, etc. Okay, is not correct. The use of cooling blanket is an acceptable non-pharmacological method of reduction of body temperature. Ensuring safe use of the cooling blanket is important in preventing injury. Assessing the skin for breaks in skin integrity is necessary so that the blanket is not applied in those areas. So if you have a client with a wound, you should not be applying the cooling blanket in the area of the wound. Okay. um, as further injury could occur. The nurse needs to review the manufacturer instruction prior to use, of course. A bath blanket should be used as a barrier between the cooling blanket and the client skin. So it is important. When we use either heat or cold in a client, we don't apply directly to the skin neither the cold or nor the heat. We need to place a barrier between the source of heat or cold and the skin to prevent damage of the skin. Yeah, very good. To prevent injury. The distal extremities and genitalia should also be wrapped with a bath blanket to prevent contact with the cooling blanket. It's important this cooling blanket should work in the core temperature, and the core temperature is in the trunk, So the extremities are not going to benefit of this cooling stuff, because it's going to be more vasoconstriction and more ischemia of the extremities. The cooling blankets are applied basically in on the trunk. okay, on the trunk. Soaking the client hands and feet in cold water and placing a moist washcloth in the client's forehead are not indicated measures to reduce body temperatures and are not part of the procedure for using a cooling blanket. Do you remember that usually you see that in movies, etc., the use of washcloths in the forehead and we, placing ice or cold water in the armpits and the groin, etc. This is not indicated. It's not indicated. So it's just a reinforcement with the scenario of our knowledge to survive in similar question. So another question. The nurse has administered the antibiotics, acetaminophen, and has started IV fluids. The nurse is preparing, just a moment, preparing a cooling blanket. The nurse performed which of the following action to ensure a safe use of the blanket. Select 4 actions. We need to limit to only 4 actions that will promote safe use of the cooling blanket. Let's see. Assess the skin for impaired skin integrity, of course. Never assessment is wrong. Soak the client's hands and feet in cold water. No, we don't involve on the extremities in this process. Place a moist washcloth on the client's forehead is not used. Review the manufacturer's instruction prior to use, of course. Wrap distal extremities and genitalia with a bath blanket. Yes, because you protect them with the bath blanket. The bath blanket is not cold. The one that is cold is the cooling blanket. That is a blanket that have circulation in the interior, have a system of tubes in the interior connected with a machine that is making circulation of cold water, okay, in the blanket, okay. The bath blanket is a blanket, is a towel that is not cold. It's to protect, okay, the client. Place a bath blanket between the clients and the cooling blanket. Yes. So once we educate ourselves about this, which is not going to harm any one of us, beginning with me, is an adequate way, no puedo borrar, an adequate way of, solving the problem. Perfect. So it is a clinical scenario that I wanted to use to discuss a little content about sepsis and management of sepsis, etc. Any question about that? Is okay? Okay, let's move to other questions. A nurse is teaching a newly licensed nurse about the risk factors for dehiscence in clients who have surgical incisions. Which of the following factors should the nurse include in the teaching setup that apply? Poor nutritional stage. I think that all of you know that the nutrition influences the healing, especially the proteic malnutrition delays the process of healing. That's why clients that have, for example, pressure ulcers in long-term care facility, etc., uh, requires evaluation of the nutritional state with albumin or pre-albumin, and a hyperproteic diet is indicated. But the other 2 parameters of nutrition that are important apart of calories and proteins are the amount of ascorbic acid, vitamin C, that also participates in the synthesis of collagen, that is the glue that heals the wounds, and the mineral zinc that also participate in the healing. Summarizing, protein, vitamin C, ascorbic acid, and zinc are the 3 elements of nutrition that are important for for um, for the nutrition of those clients. So we select this. Alter mental status. So we are talking about dehiscence. Okay, so we have 2 possibilities here. Overthinking. Overthinking. Oh, the client is alterated and is misbehaving and is not, I don't know, resting enough, is walking a lot, and this can produce the dehiscence. And the other is dehiscence is the separation of the borders of the wound that previously was joined by stitches or staples, and the mental status of the client is not affecting that. I think that the altered mental status is not a direct risk factor for dehiscence because clients are supposed after surgery to get out of bed and have early ambulation. And the fact that the client is disoriented or confused, etc., is true, have placed the client at risk for falls, but not dehiscence. Risk for elopement, but not for dehiscence. Risk for agitation, but not for dehiscence, So I decide not to mark that because remember my recommendation in the select that apply questions, okay? Only select what you are absolutely sure. But I'm afraid of the people that tends to overthink. Obesity, yes, obesity is well defined, well explained, of cause of dehiscence. The reason is that the adipose tissue, this tissue that is too thick in obese patients, especially in abdominal surgery, has low blood flow, low circulation, low amount, a small amount of blood vessels. As a consequence of that, the healing is slower. So the thicker the adipose layer of an obese client, the slower the process of joining the border of the wound. And is there in the pocket that forms in the adipose tissue where the liquid, the serum that normally is, ooze the surgery accumulate because the wound in the skin is healing quickly. The muscle, the muscle that is under the fat is healing quickly, but then the fat is healing slowly, and forms these pockets of liquid that accumulate there that make a pressure and produce the dehiscence. Obesity is an important risk factor for dehiscence. Pain medication administration. So I don't see which relation have the pain medication and dehiscence because pain medication doesn't delay the healing. Which medication delays the healing? The glucocorticoids. So if they say here administration of glucocorticoid for X reason, this is a cause, this is a risk factor for dehiscence because the healing process is slowed down, this is impaired by the glucocorticoid, but not pain medication. Wound infection, yes, it is a risk factor for dehiscence. The presence of infection of inflammatory response in the localized in the wound because get infected is going to delay the healing, the union, the junction of the borders by the collagen tissue and by the collagen substance. And this is a risk factor. So I suggest, okay, choosing these three. The other ones are not, we are not absolutely sure. Don't choose the others, okay? A nurse is teaching a client who has chronic kidney disease about limiting foods that are high in potassium. Which of the following foods should the nurse instruct the client to avoid? So we have green beans, tomatoes, bananas, asparagus, and raisins. We know that bananas are very high in potassium. We know that the raisins and any dry fruit is very rich in potassium. So these two are, we are absolutely sure. Dry fruits, raisin, prunes, dates, figs are very rich in potassium. Banana, who doesn't know that? Maybe you know that tomatoes are very rich in potassium. Okay, tomatoes are very rich in potassium. Okay, so maybe you have doubt about asparagus and green beans. Green beans have low potassium. Okay, this is something that maybe you know, maybe you don't know. So, the best, if you don't know, the best is not, don't select this option, don't mark this option, because the recommendation is mark. If you do that, you are going to have right, because green beans are very low in potassium. Asparagus, no, asparagus are high in potassium, so should be also being avoided. So the only one here that is low in potassium is green beans. All the others should be avoided. But suppose that you didn't know about asparagus, okay? So you leave that in blank, okay? You lose a fraction of the question, but you don't have penalization. So you will have probably the 75% of the question correct. That's why the strategies of marking and Salvador apply, but you are absolutely sure. When you have doubts, and it's better to leave that blank. Uh, these questions are common questions in English, guys. If you think that those questions are too easy or no, whatever you think, you're wrong. Those are very common topics, okay? This topic and this topic have been in different type of question, very common. And remember that the diet is the nutrition class is very important for English. A nurse is teaching a client about risk factor for osteoporosis, another important topic in English. Which of the following factors should nurse include in the teaching? Risk factor that increase the risk of developing osteoporosis. Sedentarism, yes. You know that the weight bearing exercise slow down the process of osteoporosis. By the contrary, sedentarism promote osteoporosis. Obesity. Obesity is a protective factor for osteoporosis. There are several reasons for that, but obese people have more weight bearing, and as I said, the weight bearing, okay, is a protective factor of osteoporosis. But the other reason for which obesity is a protective factor is women, post-menopause women, are the one that have the highest risk of osteoporosis. But obese women, okay, the adipose tissue of obese women produce estrogens. So when the ovaries, okay, fails and you have ovaric insufficiency and you have menopause and you stop producing estrogens in the ovaries, the adipose tissue continues producing estrogens. That's why this is a protective factor for osteoporosis. But these exaggerated amounts of estrogens, even after menopause, increase the risk of cancer in the organs related with estrogen. That are the breast, the ovaries, the endometrium. Okay, so those organs, okay, endometrium, ovaries, and breast, are responding to those estrogens that are continue being produced after menopause, and obesity is a risk factor for breast cancer, ovarian cancer, and endometrial cancer. Obesity is a risk factor for diabetes, hypertension, coronary artery disease, and all the circulatory problems. Obesity is a risk factor for degenerative joint disease of the knees and the hips, requiring surgery. Okay. And well, there are other many risk factors related with obesity, other cancers. Obesity is a risk factor for other cancers different from the gynecological cancers. So even if obesity is a protective factor for osteoporosis, it's not a good decision to allow obesity to develop just to protect osteoporosis. It's better to do exercise or consuming alendronate or different stuff. Aging is a risk factor for osteoporosis. You don't see osteoporosis in young women. You see osteoporosis in old women, in postmenopausal women. You don't see osteoporosis in young men. You see osteoporosis in very old men. So aging is a risk factor for osteoporosis. Caffeine intake. This is something that should be a doubt. High caffeine intake is, yes, has been considered a risk factor for osteoporosis, but a normal, a moderate or mild consumption of caffeine is not described. So I don't know. Okay, but the probably the intention of the question is to mark caffeine intake. But is this the comment that I can share with you after reviewing the literature? Okay, that only high caffeine consumers relate that with osteoporosis. Secondhand smoke is not a risk factor. Uh, um, Smoking is a risk factor of osteoporosis. Secondhand smoking is being more related with pulmonary problems. This is the way that I would be answering this question. A nurse is giving a presentation about preventing deep vein thrombosis. Which of the following should the nurse include as a risk factor for this disorder? Another select that apply question of risk factor for DVT. Body mass index of 22. So how is body mass index 22? It's normal. So it's not a risk factor. Obesity is a risk factor for DVT, but not this. For that option, we need to remember that normal BMI is from 18 to 25. So rounding, no? That's why it's important to know uh, the normal BMI. Oral contraceptive use, yes. Yes, there is a light, no important, but light on increment in the risk of DVT when oral contraceptives are used. The estrogen component of the contraceptive pill is the one that increases the coagulability and the risk of DVT. The progestin component of the same pill is not related with increased risk for DVT because you need to know that contraceptive pills have a combination of estrogens and progestin, the most commonly used. Yeah, there are pills, contraceptive pills that are only progestin. Those don't increase the risk of DVT, but the regular oral contraceptive, nevertheless, nowadays the pills have such a low dose of estrogen that the increment of the risk is mild, is not important. There are more risk in becoming pregnant, in having a pregnancy. Pregnancy have much more risk than the risk of DVT that brings the oral contraceptive. That's why doctors and the science continues prescribing contraceptive because when you place in the balance the risk of a pregnancy that is not desired versus the risk of the taking the contraceptive, the weight of the risk of the pregnancy is much infinite, exponentially higher than the risk of DVT induced by the contraceptives. Nurses need to have those concepts clear that when we are talking about risk, we need to use this balance to speak properly. So if you are not clear in this aspect, you could say, oh no, oral contraceptives are not good. All the contrary, oral contraceptives are very good because preventing pregnancies, especially non-desired pregnancies, the benefit of the oral contraceptive is huge, is huge. But yes, oral contraceptive can increase the risk, especially if the woman smokes, because you can have a woman that is a smoker and also uses oral contraceptive. So now there are two risk factors, one mild that is the oral contraceptive, one severe that is smoking. So this kind of woman should use a different contraception, or woman that has a varicose vein, for example, or a woman that is very obese, or women that have a previous history of DVT or thromboembolic disease. Those are the cases in which the oral contraceptive are not appropriate. You understand? But the regular people, the normal people that are taking oral contraceptive, benefit of using oral contraceptive. This is an explanation I need to be given, because then I could find nurses discouraging people of using contraceptive, um, because the nurse is not understanding the the evaluation of pros and cons of using determined medication. All the medication have pros and cons. All medications and all the actions, all the interventions in our work have pros and cons, have risk and benefits. And this always need to be placed in the balance to do beneficence and to avoid maleficence. No, this is an ethical and of course professional practice. Very well. Hypertension. Hypertension is not a risk factor of the vein thrombosis. Hypertension affects arteries. It's an arterial disease. It's not affecting the veins. So it's important that we discuss that. Yeah, because you can be confused in the day of the test. You have that, oh my goodness, could be or not a risk factor for DVT hypertension. Okay, remember that it's called arterial hypertension, systemic arterial hypertension. And this is a disease that affects arteries, and arteries have nothing to do with the vein thrombosis. Artery is an artery and vein is a vein. Okay, so that's the way of you remember that hypertension has nothing to do with DVT. High cholesterol produces problems in the arteries. So high cholesterol, okay, produces problems in the arteries, atherosclerosis, and serious problems in the arteries that can end in myocardial infarction, stroke, etc., but not DVT, not vein problems. The cholesterol doesn't affect the veins. Femur fractures and open reduction of internal fixation, of course, that is a risk factor. The orthopedic surgery, any surgery that requires you not to be under anesthesia, immobile for a while, and then trauma in the area of the deep veins of the legs, that is the ORIF, because a femur fracture is super risk factor for deep vein thrombosis. Anything that produces immobility, you know that the blood moves in the legs when the legs are moving. So anything that promotes, okay, immobility, that the client is not moving. Anything that promotes obstruction of the blood flow here, like obesity, like pregnancy, like a fibroid in the uterus or tumor in the uterus, promotes DVT. Anything that increases coagulability. I said the most important that increases coagulability are the estrogens. So uh, the use of estrogens, the pregnancy, yeah, are risk factor for DVT. Smoking is a risk factor for DVT. Smoking increases coagulability, the aggregation of the platelets and the coagulability. There are certain medications that you need to know that are like estrogens, um, uh, which is the tamoxifen, and the raloxifene. Those are estrogen receptor modulator, so are like estrogens, and they also increase the coagulability and the risk of DVT. Have that in mind because it's tested. Tamoxifen is an estrogen modulator, receptor modulator that is used for the prevention of the recurrence of breast cancer in some types of breast cancer. And raloxifene is also an estrogen receptor modulator used in the treatment of osteoporosis, but have as a side effect increased risk of thromboembolic disease. You need to be solid in your knowledge of those aspects that I'm mentioning here in very simple question because it's high yield for your English. A nurse is caring for a client who is post-operative following an open reduction internal fixation ORIF of femur fracture. Which of the following parameters should the nurse include in the neurovascular evaluation of the affected extremity. Very important. You know that after a problem, fracture, um, cast, or if surgery, whatever, in the lower extremities, catheterism, you need to do neurovascular assessment to for early detection of complications. In the case of this femur fracture, could be a compartment syndrome. Yeah. Okay. So what is included in the neurovascular assessment? Remember that when we are doing a neurovascular assessment of an extremity, upper extremity or lower extremity, we are evaluating the arteries that brings the blood from the heart toward the distal part of the foot in this case. But also we are evaluating the nerve that accompany those arteries and allow the extremity move and feel. So neurovascular is the evaluation of the nerve and the evaluation of no, sorry, and the evaluation of the artery. So I don't change. I don't know why. Okay, is this? No idea. Okay. Temperature. Yes, the temperature is part of the neurovascular assessment. Why? Because the blood is warm. And when the blood arrives to the foot, to the distal part of the extremity, this part should be warm. Okay. Um, uh, Ecchymosis. Ecchymosis is the spillage of blood in the site of the trauma or the surgery. Has nothing to do with the neurovascular assessment. Ecchymosis is just, blood spill in the site of the injury. So, no. Skin integrity, no. Skin integrity has nothing to do with the artery and the nerve. Sensation has to do with this, with the nerve. Sensation and movement of the extremity have to do with the neuro component of the neurovascular. Color has to do because the blood is red, and then the color of the skin of the extremities are going to depend if the blood is arriving or not. The other components of the neurovasculars are the pulses, the arterial pulses, okay, and the capillary refill. So summarizing the neurovascular, neuro, sensation, and movement. Vascular, the artery. And the artery is going to give the pulses, the capillary refill, the warm temperature, and the pink or rubish color. Skin integrity is not part of the neurovascular assessment. It's very important, but it's not part of the neurovascular assessment. The presence or not of bruises and ecchymosis is not part of the neurovascular assessment. Guys, if you have doubt what I'm explaining, you don't like to talk. That's why when I present that for MIU, I don't require your participation. But if you have a doubt or an objection, speak up. The nurse is preparing for the administration of digoxin to an older client with heart failure. Before administering digoxin, what must the nurse do first? First is an important word, okay? Assess if the client is able to swallow whole tablets. Review the most recent potassium lab test. Raise the head of the bed and check the client's identity. Assess that the apical pulse is more than 60 beats per minute. Notice that the 4 interventions are correct. This is correct, this is correct, this is correct, and this is correct. But they are not asking us what is correct or not. They are asking us what we do first. I like to explore. Okay, what do you think? What is the first that you do?
See?
Of course, let's see. Of
Yeah,
course, let's see. So the
the
first
right
that you
patient.
do, exactly, you read the head of the bed and be sure that this is the client to whom you need to give the diagnosis. After you do this, then you assess if it is the correct client. You assess in this correct client, the client is able to swallow. And then you check, the client is able to swallow, you check the apical pulse, and you check the most recent lab, because the two parameters that could contraindicate the use of the dioxin in this client, after you are sure that it's the correct client and is able to swallow, is that having a bradycardia or low potassium. With bradycardia or low potassium, you don't give the dioxin. But this is not the first. The first is to be sure that it's the correct client. So you start, assessing the potassium and the apical pulse, and then what's your name? Oh, I'm sorry. I'm sorry. Sorry for bothering you. It was not you. Okay, I'm so sorry. It was my wrong, my mistake. No, 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 no. The first is to identify the client, and two, raise the head of the bed because you give the medication with the client sitting. And then be sure that the client is able to swallow. So you can ask the client, or you can give a sip of water to see if the client is able to swallow without choking. And then that you know that you can give dioxin to this client. You look for the two parameters that need to be checked before giving the dioxin, which is the counting the apical pulse and checking the potassium level. So interesting question, in which you realize that what defines the question is the word first. Any fast reader that ignores the command of this word would probably mistake this question, because being everything important, if you don't realize that they are asking the chronological priority, what go first, what second, yeah, then just keep the question. This is an important question from my point of view for a strategy, to accept that sometimes you go too fast. No, así no me gusta. The nurse must inform a client the results of a test needed to decide an intervention. Okay, it is a scenario. You need to talk to a client. You need to talk about a test that just came, and doctor ask you to inform the client about the test, and the result of this test will decide what to do. So the client need to start thinking in the possibility of the procedure. So when the doctor comes, the client has already the information and can, together with the doctor, decide if the procedure is done or not. The client is ambulatory, so the client is able to walk, and the client is in a semi-private room. A semi-private room is a room that have another bed or beds with other people, with another client separated by a curtain. This is very common. Curtains or dividers separates those beds. When entering the room, the nurse sees, remember, the nurse is entering to inform the client of a result and to discuss an intervention. The nurse sees the client's spouse and children are visiting him. So see the scenario, trying to visualize the scenario. Which is the best approach to follow to communicate information to the client at this moment? Ask the client if the family can hear the information. Request the family to leave the room while the information is delivered. Take the client to an area outside the room to give the result. Check in the client's chart if the family is authorized to receive the client's information. What do you think, guys?
A.
The client, the family. Suppose, suppose that I am your papa or your abuelo. Okay, suppose that I'm your papa. You are your father. Yeah, and the nurse in front of me ask you, do you want your dad to know about your private stuff? Uh, in front of me, suppose that you are your father. Would you like to tell the nurse, no, I don't want my father to know my private stuff? Do you notice predicament, the conflict that I'm placing you when I'm asking you, okay, in front of your father, if
No,
you,
igual.
it's no good, ¿verdad? Just like
No,
that is
D.
no good.
Mhm.
So that. And what about the other guy?
D.
Because remember, there
D.
is
D.
another guy. There is another guy there. So okay, request the family to leave the room when the information is delivered. Okay, maybe the family will get upset, no? But it's okay. It's okay. But what about the other guy? There is another guy separated by the curtain. Suppose that the result if you have cancer, you have HIV, you have tuberculosis, you have hemorrhoid. You understand? So, okay, B is better, but there is a guy in the other room. The family left, but there is another guy that can hear your information. Don't you think that it's better to take the clients? The clients is in blood, but the client can walk. Okay, can you accompany me a moment to an area outside the room and talk in private to the client so neither the family nor the other, the other guy that is hospitalized in the same room are hearing, and then the client decides to give this information to the family or not without any pressure. Don't you think this is more, es más mejor, is better? What do you think, guys? I want to hear because these questions is a reproduction of an actual Nclex question, and we don't know the answer key. We don't have the answer key. Those were the four scenarios in this situation. What do you think? I want to know because I always ask my students their point of view because it's going to help me. Because from my point of view, the best is Z as in cat. I want to know what you think. You're hard, guys. You're very hard. Okay. The nurse is caring for a newborn with an Rh negative ¿qué es esto? Mother. Oh, sorry. Mother. Immediately after delivery. Which of the following action would be appropriate? Okay. The mother is Rh negative and the newborn is cared by you immediately after delivery. Which following action would be appropriate? Perform Apgar assessment at 5 and then 10 minutes. Suction the nose, then the mouth. Administer Rogan IM in vastus lateralis. Place the infant skin to skin with the mother, with the parent. Okay, probably you don't want to speak. In this case, the Rh negative is just a distractor. Is just to distract you. Um, of course, the Apgar test is done at the moment of birth in 1 minute, and then repeated in 5 minutes. Okay, and it is incorrect, so we rule out this. Uh, when the baby is born, in the moment of birth, first we suction the mouth, and then we suction the nose. It's very important that the first that we do when the head of the baby comes out from the opening of the vagina is to suction the mouth. Once in the next contraction, when the rest of the body is coming out, the first that the baby is going to do when exposed to the cold air is to cry, and it's desired. So the first breath of a baby, of a newborn, is crying. So the first um, intake of air is going to be through the mouth. The mouth is coming with amniotic fluid, secretions, vaginal secretions, and blood. It's important when the baby takes air for first time when coming out the uterus, okay, having the mouth as clean as possible to minimize the aspiration of undesired secretions. That's why the first to suction of a baby uh, when the head comes out is the mouth, because it's going to breathe through the mouth the first time, because the first breath is going to be crying. This is the rational. Later, when the baby is not crying anymore, is sleeping, the baby will be breathing through the nose. They are obliged nose breathers. But the first time that they breathe is through the mouth. That's why you suction first the mouth, second the nose, and that's why this order is not correct. Babies don't receive the ROGAM. This is given to the mother, not to the baby. So the best answer to these questions is place the infant with the mother skin to skin. That you know is an adequate intervention that prevents hypothermia and promotes bonding. The nurse is caring for a client who received sodium polystyrene sulfonate and furosemide for the treatment of potassium blood level 6, which EKG findings suggest that the treatment has been effective. Okay, tall peak T wave. Tall peak T wave are seen in hyperkalemia. If they are asking me that the EKG findings shows improvement or correction of the hyperkalemia, this cannot be the answer. PR interval of 0.18 seconds. Maybe I don't have knowledge about this. Presence of U wave. U wave are present when the potassium is too low. So the desired outcomes is not to produce hypokalemia. So this cannot be the right answer. And then the QRS duration of 0.20 seconds, probably we don't know that. So in the real scenario, in the real life scenario, after ruling out that can be ruled out with the knowledge that you have, you work between B and D. And if you don't have any idea, at least you have a 50% probability of having a right answer if you are guessing. Okay, if you're guessing. But you need to know that the PR interval, that is the distance, okay, between the beginning of the P and the beginning of the QRS, this interval, the PR interval, is between 0.12 to 0.21 seconds. So 12 on hundreds of seconds to 21 hundredths of seconds. So if you divide 1 second and 100 parts, 12 parts to 21 parts is the range of time that lasts this interval. It's easy to remember because notice that if you invert 12, you have 21. This is a very old trick that we use when we were students to memorize the PR interval. This interval, the duration of this interval is important because it what defines the different degrees of AB blocks. So the first degree of AB block is when this is more than 0.21, the duration. And then when it start appearing, okay, progressive prolongation is the stage 2 or AB block, MOBITS 1, etc., etc. So that's why this interval is important. The duration, the duration of the QRS should be below 0.10, 0.10. Okay, so 0.20 is too much duration. 0.18 is in this normal range, and this is okay. When we have hyperkalemia, we have widening of the QRS, so the QRS is lasting longer than normal, and we have also prolongation of the PR interval. So what we are looking here is that the parameters are normal, and the best answer of these questions could be B as in boy. As I said, those are questions that more or less have been tested in English. We never know questions like this if they are evaluated or not. Remember that in your English, you're going to have 15 questions not evaluated. I think that this is not important for a nurse to know the exact duration of the interval because it's not required. I think that the T wave and the U wave is important. You should know this is very basic, but this is not important. So that's why I suspect that the question like this, if I have this question, my anchors probably is not evaluated because it's not important for the nurse to know that. A client is diagnosed with a lung and meningeal cryptococcosis. So another weird question, another topic that could somebody had in his anchors. Cryptococcus, okay, is a fungus. This fungus can affect mainly any part of the body, but especially the lung and the meninges. But this fungus rarely affects normal people. Used to affect people that are immune suppressed, people that are taking high doses of glucocorticoids, people that have organ transplant and need to take immune suppressive treatment, people with acquired immune deficiency like the HIV, etc. So it's the most important to know about this cryptococcosis. Can produce lung disease that is experienced like a tuberculosis with fever, cough, weight loss, lung, X-ray, abnormal X-ray, or meningitis. Which of the following intervention the nurse anticipate will be required? An order for antibiotic azithromycin IV is a fungus. Fungus are not treated with antibiotics. The antibacterial are treated with antifungal medications, especially the azoles, okay? Fluconazole, um, uh, itraconazole are the ones I think are used for cryptococcosis. An evaluation of the client's house water heater because water is the reservoir. No, the reservoir, the water reservoir of this infectious disease that you should know is the Legionnaire disease, which is a pneumonia produced by a bacteria called Legionnaire disease. Okay, and this is nothing to do. So C says a test for HIV to investigate acquired immune deficiency. It sounds the right answer. D, initiate isolation for dropless infection control. No, this kind of stuff, the infections that are opportunistic are standard precaution, are not passed from person to person, are not passed from immune competent uh, persons and to other person. Okay, so the answer is investigate immune deficiency. So it's not going to harm you if you see there's a infectious disease to know this is one of the opportunistic infection that can affect immune suppressed people. Select which of the following nursing procedure requires the use of sterile gloves. Let's see. Changing the dressing of a central line. Yes, in some moments it's going to require sterile gloves. They don't mention in which moment. So remember, to change the dressing of a central line, first you use clean gloves, not sterile, to remove the old dressing. But once you remove the old dressing, you need to remove your clean gloves and don't sterile gloves to do the scrub and the placement of the new dressing. Inserting and indwelling urinary catheter, yes, this requires all time the sterile gloves. Removing a peripheral venous access device doesn't require a sterile glove. You should use clean gloves for standard precaution because you anticipate that small amount of blood can be spilled when removing the catheter. But you don't need to use sterile gloves. You use clean gloves. Inserting a nasogastric tube. The nasogastric area has a flora, and for that reason requires clean gloves for standard precaution, but doesn't require sterile gloves. Suctioning an endotracheal tube with an inline suction system. This is tricky. Okay. There are there are two ways of suctioning an endotracheal tube. The primitive way. Okay. So suppose that this is an endotracheal tube that is inside the trachea. Okay. See, inside the trachea of a client. Yeah. Yeah. Inside the trachea of a client. So you can take a catheter. Yeah. With the catheter with a sterile globes. Introduce the catheter. When you feel resistant, you remove, and then you suction while coming out with the sterile catheter and the sterile globe, and you discard this catheter. Yes, so it is a way of doing that. But in usually those clients have inside inside the tube have already a catheter, okay, a catheter, that is entering in the tube. The catheter is parked outside, is connected to suction, okay, but is covered by is covered by a sterile protection. In those cases, when you want to suction, you put regular clean gloves, standard precaution, regular clean gloves, okay, regular clean gloves, and then you push the catheter inside the tube. Remember, the catheter is used, is there and is reused, no? It's protected by a, um, you know, uh, a sterile inside, covered, no? And then you push the catheter, you suction, and then you pull out the catheter, and the catheter stays there, okay? It stays there, okay, the all time. So this is an inline suctioning system. This is an inline suctioning system. In that cases, the gloves that you are going to be using are clean, not sterile. So it depends on the method. If there is not an inline suctioning system, this is the regular that you study in the lab or clinically, or the way that we suction a tracheostomy, you need to wear a sterile gloves. But using an inline system, you don't need to use a sterile glove. Suction tracheostomy, yes, because tracheostomy don't have like the endotracheal tube, those inline suctioning system. You need to have a sterile glove. Insert the hover needle in a porta cath, yes. The porta cath, you should know what it is. It's those devices that are place that can be lifelong place under the skin, close skin of people to have a central vascular access, requires a special needle called Hoover needle, but the insertion of those needles in the porta cath is 100% sterile. So that's why it required not only sterile glove, requires a mask and all the sterility possible. The nurse is transferring a client from bed to wheelchair soon after receiving a dose of IV morphine. So the patient is sedated and with low blood pressure and is moving from bed to wheelchair. Okay. While doing the transfer, the client becomes dizzy and falls into the wheelchair. So trying to visualize now that you are transferring the client from the bed to the wheelchair, and the client becomes dizzy, and you can't make the client, okay, uh, fall in the wheelchair, no, fall in the wheelchair. Which will the nurse do next? Administer PRN naloxone, call the rapid response team, assess vital sign, assist the client back to bed. Don't move the client back to bed because the client is too weak and is going to fall, okay, when you move the client, because you were lucky and the client fell in the wheelchair, and the wheelchair is okay, is safe, okay, is okay, is safe. If you move the client to the bed, it's going to fall. So you discard that. You don't need to call the rapid response team unless the client is critically ill. To know if the client is critically ill, you need to assess the vital signs, specifically the blood pressure and the heart rate of the client and the respiration. The client is only dizzy and weak, and that's why he fell in the wheelchair. You don't need to administer naloxone unless the client has respiratory depression arrest. Why? Because if you administer naloxone, the client is going to be in pain with a withdrawal. It's going to be worse the solution that the disease. So assessment is the first, and it's an easy question. I think that nobody can fail this question. The important is to understand the scenario, understand what is happening in the scenario. The nurse is carrying out the provider's order for a client who presented following skin lesion 2 weeks after the summer camping trip. Okay, so what we have here, we have a lesion that is red, have a ring of circle of erythema, and then the center is clear. And again, in the center, you have another solid circle of erythema. And they say that it appears uh, 2 weeks after a camping, okay, a camping. So the characteristic of the lesion and the fact that it was camping make us suspect that the client could be having Lyme disease. Which of the following order should the nurse object? Question. Penicillin, cefuroxime, clotrimazole, doxycycline. So we have here a combination of medication. Some are antibiotic, one is an azole. Azoles, as we mentioned before, are for fungus. Clotrimazole, ketoconazole, miconazole, itraconazole, fluconazole. So obviously this is the answer. Cefuroxime is a cephalosporin, can be used for Lyme disease. Penicillin can be used for Lyme disease, and tetracycline, doxycycline can be used for Lyme disease. So an easy one, an easy one. Anyone that knows a little of the pharmacology. Another um, clinical judgment scenario. A 55-year-old client who is homeless is brought to the ER at the veteran hospital by the emergency system, who responded to a call about a person who collapsed in the street. On arrival to the ER, the client was awake but sleepy and extremely weak. Following an assessment and lab test, the client was admitted to the medical unit. Okay, so the only evidence here that he fell, collapsed in the street, and is very weak, but is awake. The nurse in the medical unit performs an assessment on the clients and reviews the lab test result from the emergency department. So the nurse that received on the floor the clients receive the clients and evaluates what is brought by the client. The nurse documents the following physical exam findings. History of present illness. Reports diarrhea for 4 days. So this client is having an acute diarrhea, could be dehydrated. 8 to 10 episodes per day. So diarrhea is a sort of loss of liquid and electrolyte, and it could explain the weakness of the client and the collapse. Described as watery associated with abdominal pain, decreased appetite, and nausea. Went to the clinic at the veteran hospital and they prescribed loperamide for the diarrhea. Loperamide is anti-motility, anti-intestinal motility. Okay, uh, is it the Imodium? Has been staying in the homeless shelter for the past 4 days. Reports that the diarrhea is resolved, but is feeling extremely weak. It's interesting. The diarrhea was self-limited, so probably was a viral diarrhea, something that is not something that the own immune system could overcome, but as a consequence, diarrhea, okay, probably is having a deficient of liquid and electrolyte. That's why it's so weak. Past medical history reports no prior health problems. Family history state unknown. Social history report it's a veteran, has a history of drug and alcohol abuse and began using substances after leaving the military, but sought help and denies current use. So it is clean now, as per the client. Was a former manager at the casino, but lost the job because drinking and drug use. State is homeless and floats around, staying here and there with acquaintances, but mostly stayed at the shelter. Currently not sexually active, no history of sexually transmission infection, medication, loperamide, 2 milligrams tablet, report being taken up for 4 to 5 days. Red blood cells 4.8 normal, white blood cells 11,000, slightly elevated. Hemoglobin 12 is in the lower limit, but it's normal. Hematocrit 26, 50. So the hematocrit is much, much higher than expected. If you multiply the hemoglobin times 3, you have 36, but the hematocrit is 50%. So this hematocrit is increased. We should note that in dehydration, the hematocrit increases, okay, beyond proportion with the hemoglobin. Any one of you that doesn't know that should be aware of that. It's very useful to diagnose dehydration. Platelets are normal. BUN 24 a little high, but also the BUN elevates when there is dehydration. The creatinine is normal. When you have normal creatinine and elevated BUN, this is dehydration. If both are elevated, it's renal failure. But when the creatinine is normal and the BUN is elevated, it's dehydration. So we have two parameters plus the clinical story to think in dehydration. Sodium 150, a little high, could be compatible with the loss of water. Potassium 3, low, because the diarrhea, the intestinal liquid diarrhea produces a lot of hypokalemia. Um, Stool culture Clostridium difficile toxin. So this client is having a diarrhea associated with Clostridium difficile. Oh, no, sorry. I apologize. I'm not reading. I'm assuming a culture for C. diff is pending, has not yet arrived the result. Sorry. Okay, so we don't know yet if the client has C. diff. It's interesting that this client has no history of intaking of antibiotic, that the usual scenario of the C. diff. Uh, Probably this client had a viral diarrhea and intestinal flu. Let's see. Um, the physical exam, temperature 108, so a low-grade fever, heart rate 100, so upper limit, but irregular. This is important. Irregularity suggests cardiac dysrhythmia, which is very important in a client with dehydration and electrolyte disbalances, especially hypokalemia. Radial pulse is thready. Thready means that it's weak, you know, and it's because the dehydration problem, the decreased volume. Uh, Respiratory rate 20, upper limit, shallow. Why shallow? Because probably muscle weakness. Why muscle weakness? Because probably the low potassium. When there is low potassium, the muscles are very weak. And to breathe, you need muscle. So probably that's why the respiration is shallow. Okay. Uh, the other reason for having shallow respiration is you have pain when you breathe in. This is another to have in mind. Um, Blood pressure 100 over 58. For a person of this age, it sounds a little low. Uh, Again, it would be very interesting to know what is the baseline blood pressure of the client. Oxygen saturation 92% room air, a little low. Pain 2 on 10. Where is the pain? Maybe abdomen. Okay, so have a light pain. Very good. Integumentary skin. Warm skin is dry. Ecchymosis noted on the left arm and shoulder. Oh, because the client fell. Yeah, the client fainted in the street. That's why the ER, the EMS, pick up the client. So we need to be careful. This client is not having a dislocation or fracture in the left shoulder. Oh, this is the pain. Report no pain and that fell when trying to get up to go to the bathroom at the shelter. Well, this is pain 2 and 10. Okay, a contradiction. Respiratory 20, shallow, long sounds clear to auscultation bilateral, but diminish. We already talked about this. Each time you are in presence of a clinical scenario, each finding you need to try an explanation, an interpretation, and correlate everything with the same diagnosis, similar diagnosis. Cardiovascular heart rate 100, irregular. No S3, no S4. This goes against heart failure. No murmurs, rubs, or gallops. Cardiac monitor. So ST depression and flat T wave and prominent U wave. Peripheral pulse diminished. This is a suggestive. This finding suggests hypokalemia. The ¿cómo se llama? The U wave suggests hypokalemia, and also together with the U wave, the depression of the ST segment and the flat T wave support that. Um, Gastrointestinal reports dry mouth, of course, because he's dehydrated, and thirst, and not eating or drinking much. No nausea or vomiting. Bowel sounds hyperactive times 4 quadrants. Probably because they still have inflammation in the intestine, or the enterocolitis that had. Tenderness to palpation in right lower quadrant and left lower quadrant. Pain 2 and 10. Um, report stomach gurgling because increase the vowel sounds. Negative Murphy. Murphy is for the gallbladder. So the sign of Murphy becomes positive when there is inflammation and pain in the gallbladder. The gallbladder is under the liver, and the liver is under the ribs in the right side. Yes. So when you put your hand in the abdomen of a client, just under the last rib, the costal border, and you ask the client to breathe in, the liver that is behind this, the liver that is behind this will descend with the gallbladder. And if the gallbladder is inflamed, okay, is inflamed, will touch your hand, and then the client will experience pain and will stop the inspiration. This is the Murphy sign, but it's negative. So the gallbladder is okay. No rebound tenderness. Remember that rebound tenderness is found in peritonitis. No costovertebral angle tenderness. This is important. In the back, not in front, in the back, okay, in the area where the spine connect with the last rib, okay? This is called costal vertebral angle. What you have here are the kidneys. If the kidneys have inflammation, the palpation and the percussion of this area is extremely painful. So not having costovertebral angle tenderness say that the kidneys are okay. No bowel move since admission, placed on contact precaution. They put the clients on contact precaution, but is not necessary. Your battery is running low. Oh, just a moment, guys. I having a crash here of energy. I don't know why. Okay, just a second. Is it okay? Disconnected. Disconnected. Why is saying that? No, it's not working. Okay, sorry for the interruption. I thought. Was running out of battery. Okay. You need to know that the Center for Disease Control says that if the client is suspected Clostridium difficile, should be placed in contact precaution. The other type of diarrhea don't require a contact precaution unless the client is incontinent. Okay, so it's okay, it's correct to place the client contact precaution because the nurse is suspecting Clostridium difficile, C. diff. That's the rationale for placing the client in contact precaution. IV fluid 0.9 normal saline infusion at 50 per hour. Notice that this is what we use in patients that have dehydration, the isotonic IV fluid. IV side dressing on right hand, intact, no redness or swelling. Neurological awake, alert, and oriented time for adequate attention span. Musculoskeletal, generally weak. We talk about this weakness and the hypokalemia, moving all extremities, including left arm and shoulder without restriction. Looks like there is no big problems in this trauma of the shoulder. Genitourinary report infrequent voiding. Oh, it is important because the dehydration, no? But remember that the creatinine is normal, so still the kidneys are okay. Voided 100 milliliters concentrated urine. The urine is concentrated because it's producing antidiuretic hormone to compensate the dehydration, to save water in the ER. And 50 milliliter concentrated urine arrived to the unit. So it's PIM 50, 50, this is 30, 30, 30, and arrive, yes, more than 1 hour. Okay. Uh, let's see, which of the following findings, three findings, okay, which of the following three findings, so we need to limit to three, are of immediate concern. So BUN, white blood cells, hematocrit, temperature, bowel sounds, sodium result, potassium result. Obviously, the potassium result is the very high concern, no? Obviously, the cardiac manifestation of the low potassium are of very high concern, very high concern. Yeah. Um, the other concern, the other concern that we need to have here is the sodium and the dehydration. Yeah. Um, so we need to choose between the potassium, the cardiac monitoring, findings, and the high sodium, which is in 150, and the sign of dehydration. The sign of dehydrations are high hematocrit, high BUN. So because I have two signs of dehydration, BUN and hematocrit, my instinct says I only have one left. So I'm not going to select dehydration. So what is left then to select is the sodium level. And then I select the hypernatremia. So the hypernatremia, the hypokalemia, and the findings in the toxicity in the heart of the hypokalemia I, are the most important that requires immediate follow-up. I notice your silence, so I notice that you are not objecting this decision. So now let's see. Let's say this question. Select to specify if the assessment finding is associated with hypokalemia or dehydration. The assessment finding could be used more than once, okay? BUN level, it is related with dehydration. The elevation of the BUN with normal creatinine is dehydration, nothing to do with hypokalemia. Hematocrit level is related to dehydration, nothing to do with hypokalemia. Temperature, elevation of the temperature could be seen in dehydration, but not in hypokalemia. Yes, dehydration can produce fever, especially in children. electrocardiogram electrocardiogram findings is related with hypokalemia. Dehydration doesn't produce those EKG findings. The potassium level is, of course, related with hypokalemia, not necessarily with dehydration. You can be dehydrated without alteration of the potassium. Sodium level, sodium level can be perfectly explained by the dehydration, but not by the hypokalemia. Diminish peripheral pulses. Okay, this can be seen in both because the weakness in the heart and the weakness in of the pulse because the decreased bulimia can be both present diminished peripheral pulses. So it could be the way of surviving this question. Remember that all those questions have partial credit. Okay, if you commit the one or two mistake, still you have some credit. I don't know if you are aware that the passing rate in all the country since the new generation questions have been introduced have, has increased. So people are passing more uh, since April. Still, the cost has been evaluated, but the idea is that even if those kind of questions consume a lot of time, are relatively easy questions. So let's do this question. The priority needs for the client that should be addressed at this time includes and So from here, replacing potassium, obtaining a stool culture, reducing the temperature, obviously the priority here is replacing the potassium. It is a big priority. And the other, replacing fluid, yes, decreasing the sodium level, decreasing the hemoglobin level, no. This is going to be corrected when you replace fluid. So the next is going to be this. You move those uh, uh, to the line. The nurse would plan for which of the following intervention scenarios that apply. Let's see. Social services consult. Guys, we have a client that here is homeless, a veteran that is homeless. So obviously we are going to require the help of social services. Intravenous potassium, yes, we anticipate that the doctor will, administer intravenous potassium. Why? Because the client first is having already signs of cardiac toxicity in the EKG of the low potassium. This potassium need to be corrected, okay, as soon as possible. Second, the client is having some intolerance to the orals, not consuming enough food. So the best is to correct that with IV potassium. Diuretic administration is obviously contraindicated. Antiemetic administration could be anticipated if the client has nausea. Increased intravenous fluids, okay, it is indicated obviously. The hospital physician prescribed 1,000 milliliters to define in normal saline with 40 equivalents potassium to infuse at the rate of 100 milliliters per hour, so they increase from 50 to 100, and repeat potassium, sodium, BU, and creatinine in 4 hours. Select two, yo puse aquí roller. Okay, select to indicate the nursing action listed below that are indicated. Okay, so to decide if it's indicated or contraindicated. Discuss renal function with the physician. Of course, that is indicated. This patient is at risk of pre-renal, because the dehydration, renal failure. Use an inline drop rate controller. Okay, this is this device that we are seeing in the IV tubing that has the tubing is coming here and has like a wheel. Okay. Okay. There are other models. No, there are some of them that have also like a wheel, but have the possibility of twisting that to select the number of drops per minute. Okay, use of an inline drop rate controller to ensure adequate flow rate. It is contraindicated. This delicate case require a pump. The pumps, the IV pumps that are much better than these kind of devices to have an exact IV administration of fluid, especially if you are administering potassium. You cannot depend of those devices to administer potassium, because if accidentally these rollers move, etc., the potassium can pass too fast and the patient can even die. So IV pump is necessary. This kind of devices is not appropriate. Have IV push potassium available should cardiac rhythm worsen. IV push potassium is used only in criminals when they have the death penalty. So this is contraindicated. We don't give IV push potassium, okay? Monitor intake and output during administration, of course, is indicated. Rotate, very important, rotate and invert the IV bag containing potassium frequently. Guys, the IV bag, the IV bag that is connected to the passing the tubing, okay, have the D5W in normal saline, and the pharmacy added the 40 milliequivalent of potassium. This potassium nowadays is administered in the pharmacy. So it comes from the pharmacy with the potassium. But the potassium tends to be more dense than the IV fluids and tends to precipitate, not precipitate, but go concentrate in the bottom by gravity. Gravity is pulling in this direction. So then you could be passing a higher than desired concentration of the potassium to the client if you don't move or invert frequently the bag to evenly distribute the potassium in the liquid. This is what means this, okay? Rotate and invert the IV bag containing potassium. It is indicated. Stop the infusion and contact the physician if the client report burning at the IV site. Okay, it is controversial. Burning at the IV site, if there is a peripheral venous access device, is expected when administered potassium. Of course, could be also a sign of infiltration or extravasation. Yes, you need to assess the site if the client is complaining of the burning sensation. But you need to know that this is a common, almost constant complaint of clients receiving peripheral venous IV potassium. That's why the potassium should be given very diluted, like in this case, no? And that's why it's much better to give the potassium through a central catheter than from a peripheral catheter. Laboratory studies were repeated and prescribed, and the results were reported. The nurse reassessed the decline and compared the current finding with the previous assessment finding. So now the BUN is 20, improve, improve. The creatinine is 0.9, unchanged. Sodium 145, improve. Those questions are stupid, they're silly. Potassium 3.3, okay, this is not good. Potassium now is lower, is should be another option here says deterioration or not improve, because it's unacceptable that the potassium drops below the normal. So I don't know how it's a mistake of this. Voiding 50 to 75 milliliters per hour, slightly concentrated improvement. A temperature 100.8 is not, sorry, improvement is unchanged. Apical pulse 100 irregular, radial pulse thready and weak, unchanged. Cardiac monitor ST depression with flat T wave and prominent U wave unchanged. Peripheral pulses easily felt and a strong improvement. So those are, stupid, okay, stupid question. Okay, guys, this is what I have for you today. You have any question, any doubt? Are you okay?
No,
Well,
Professor, thank you.
if you're okay, let me check your attendance and people. Okay, and have a good night. Thank you for coming back, and good luck in your Nclex the day that you have it. Bye bye.